Okay, aerosolized medication therapy education, which is nebulizers. Goals of aerosolized medication delivery, which are the handheld nebulizer or the small volume nebulizers, or little devices that you do the breathing treatments with, are to relieve a bronchospasm, deliver medication, improve the effectiveness of the cough, hydrate secretions, or aid in bronchial hygiene. Treatments are given in different intervals depending on the doctors. Accordance, of course, you all know that doctors can give it anywhere from every hour, every 2 hours, 3, 4, basically anything they want.
All day, every day.
Yeah. Indications for treatments: bronchospasm, asthma, reactive airway disease, CLP, bronchitis, emphysema, trach patients, tenacious secretions, which is throat thick secretions. Sputum induction for diagnostic purposes. That's when they go like have a bronch or something like that. Bronchiectasis, cystic fibrosis, and severe laryngitis. Some possible adverse reactions to the neb medications include allergic reaction to the medication being delivered, mucus plugging, bronchospasm, nervousness, tachycardia, hyperventilation, chest pain, palpitations, dizziness, lightheadedness or headache, tingling of the fingers or tremors, nausea, and the big one is nosocomial infection and contaminated delivery device.
What is that?
That is if you do not put the device back into the bag whenever it's done and over.
You don't cleanse it properly.
State now is saying once it gets done, it needs to be washed out and then put back into the bag.
Yep.
Okay.
One of the facilities that I go to, they actually tagged one of the nurses on it because when she got finished, she put it back into the bag and she did not clean it. So when you get finished, wash it out, put it into the bag.
Just warm water, right?
Yes. Because they're changed out every week, so you really don't have to worry about scrubbing it or anything. Also, too, big thing is dating it. I'm not for sure how you guys date your equipment or anything. I mean,
Piece of tape and
I usually write it on the actual nib itself. They didn't like where I wrote it, and I wrote it with a marker. They didn't like that. They actually want.
So what were you supposed to do?
They're wanting actually like one of the tabs, like like one of
Like
the.
you do on IV tubing?
Mhm.
That's
I know.
that's more of an infection issue than writing it right on the thing.
Mhm.
I always state my oxygen tubing right on the hub.
Yep, that's where I did, and they were actually in the building with me, and I actually had a trach patient, and I actually was dating all my stuff because I went from the top to the bottom all the way down, and they didn't like because I was taking the marker and writing all the way down. They couldn't visually see it, so they wanted an actually piece of like
all you gotta do is look.
they like the little tabs or whatever you write the date and whatever. So they couldn't see it. They just wanted to see that sticking out.
But I
so
mean,
they
on
could-
some patients that presents a choking hazard if a patient gets a hold of that tab and pulls it off.
Every other facility I've ever been in does the same way that I do it.
Yeah.
But
That's just all.
I think they was just being finicky and picky that day. But
That's a
anyway.
nice word. We're on video. Continue.
Sorry. Anyway, the proper way of doing a breathing treatment is make sure you verify your physician's orders, gather all your equipment, observe your universal precautions, make sure you wash your hands, place your patient upright position, whether it be on the edge of the bed, sitting in the upright position, or even if it's in a wheelchair. Assess your patient's breath sounds, heart rate, and respiratory rate. Always plug in the compressor and test its function to make sure it's working. And then turn it off. Connect your tubing to the actual device, whether it be your oxygen source, which you guys don't use that, you just use the little air compressors. Remove the top off of the device, put your medication in there, attach whether it's the mouthpiece, aerosol mask, or the trach mask. Here, I don't know if you can see on there, you got the mouthpiece, you have the mask, and then you have the trach mask. Use the mouthpiece. You want to make sure you attach the reservoir tubing, which is a little either clear piece or the blue piece on there. Increase the medication delivery. I know some of the patients don't like for that to be on there, but make sure it has to be on Turn on the air compressor and make sure you have a mist producing. Sometimes if you don't have a mist producing, the little piece that's inside of the cup could be stuck to the bottom of it, or it could be defective. Get you another neb kit and start all over again. The treatment should last approximately 15 minutes, depending on how much medication you have in there. If you have more than one medication, then it's going to last longer than 15 minutes. Check your filters and the condition of the nebulizer machine. If treatments are a little too lengthy, if you have the little cream color machines, those things are ancient. They tend to last a little bit longer, but if you have the newer ones, they should last only about 15 minutes. While giving the treatment, you want to try to instruct the patient to breathe about 16 to 18 times per minute. Try to get them to take a deep breath in, hold it, and then blow it back out. A lot of these little patients can't do that, but try to instruct them so they can get the proper deposition of the medication in their lungs. Here's the big one. You'll monitor the heart rate before, during, and after. So that means you need to go in the room while the treatment is going on, but you're supposed to stay in the room while the treatment's going on. Especially if state is in the room. If you don't, you will get tagged. So, but go in the room while the treatment's going on, and if the heart rate is above 20, you need to stop it.
Above 20 more than what it was at baseline.
Yes, say if it started out being 80 and it's 100, you need to stop and call the physician and let them know, because a lot of these little patients can't tolerate albuterol. So then they need to be switched over to like Zopadex. Okay. When the medication gets low, tap on the side of the actual nebulizer so you can get all the medication. When finished, place the nebulizer in a labeled bag with the patient's name. Basically, we don't really put the name on the bag. We just basically put the date on it, because that's kind of like a HIPAA thing.
Rinse it out first.
Right. Change the nebulizer out weekly according to the company's policy. Documentation is a big thing, because if I did a treatment and Judy comes behind me and say Miss Jones's heart rate went up by 20 and I don't document it and I call the physician's order, she comes behind me, same thing happens. She's going to get yelled at by the doctor saying, well, Angela just called me and I changed the order to Zopadex or something. Well, she's not going to know that. If I don't document all that, how is she going to know it? So I always say be kind to others when it comes to documentation. That way you document everything. Okay? You make sure you date and time of therapy, type of medication you use, equipment used for a treatment, breath sounds before and after, heart rate before, during, and after, respiratory rate before and after, what they cough up, include the amount, color, and consistency, patient's response to the treatment, if there's any adverse reactions or any interventions, the effectiveness of the therapy, your signatures, your credentials, and you had to return any used medication to proper storage, and notify appropriate personnel if there was any adverse reactions. Okay? You know, I know you all have a spot on your Mars and stuff that you all have to chart, but put this stuff in your notes. If there's something that's not in your notes, this is some good stuff to put in your notes. Okay?
Plus, it has to be in for reimbursement purposes.
Right. Exactly.
Reimbursement.
Yes. Medicaid will not pay for nebulizer for the respiratory therapy portion of the billing if the documentation is not there to support it.
Right. Medicaid requires, this is the only one that needs to be done every year. Nebulizer therapy. And if it's not done, then you guys do not get reimbursed for it.
Nope.
Yeah. So it's important that those things are documented.
And it's a significant financial loss. Significant.
Yeah.
Not to mention the fact that the notes tell you, if a resident goes along and has been very stable for a year and all of a sudden they start having changes in how they're responding to a treatment, that tells you that something is going on different with their metabolic issues, with their respiratory issues.
Somebody's calling me.
I mean, if they've tolerated albuterol for a year and all of a sudden they're not tolerating it and the respiratory rate's spiking and they're having bronchospasm as a result, I mean, you need to start looking at what's going on,
Right.
why that's happening.
Right. Clinical considerations, follow your specific policy and procedure. Patients should be monitored during the first treatment of any medication, particularly a neb treatment, because of the rapid onset of action when drugs are delivered directly to the respiratory tract. If your heart rate changes, it's greater than 20 points above the first. If the heart rate changes greater than 20 points during a treatment, it's considered an adverse reaction. The treatment should be stopped and the physician should be notified. When assessing the patient, listen to the lung sounds bilaterally and note where abnormal sounds are heard and their quality. Don't just put clear, diminished. Put what you hear. Bronchi, rails, wheezes, whatever. Because clear diminished is not going to get it. And you all document clear diminished, clear diminished, clear diminished. And you all keep doing this. They're going to notice a pattern that you are documenting. Then all of a sudden, somebody comes behind you, puts wheezes, and then clear diminished, wheezes. You know, they're going to notice that. So actually document what you hear. Record the patient's objective level of shortness of breath, if any. The common medications you guys are going to use is the albuterol, the Zopanex, Atrovent, which is to be the albuterol and the Atrovent also, which is the dual neb, and then the Pulmicort. Okay? Pulmicort is given twice a day. Okay? There's two doses. It's the 0.25 and then there's 0.5 milligrams. Okay? That really needs to be given with the albuterol, or it needs to be given with the dual neb or the Zopanex. It shouldn't be given by itself. The reason saying is, why give a steroid, which is the Pulmicort, by itself?
You have to dilate the bronchioles first so that the cortisone can get in there and do its job.
You should do it with a albuterol, Zopanex, or a dual neb, and open them up, and then deposit the steroid.
So you should do those separately.
You can put them. It says to do it separate because it shouldn't be in the same cup, but you could actually give them in the same cup together. The only thing it's going to do is foam up a little bit.
Okay.
Okay. Now, here's another one that's not in there. Is the Mucomist. Okay, this is the one that smells like rotten eggs. Everybody loves the Mucomist. You cannot give Mucomist by itself. It has to be given with a bronchodilator. Okay, because if you don't give it with a bronchodilator, you're going to cause them to have a bronchospasm. Okay, which means that they're going to start off in worse shape than they were. Okay, so that one can be given with the albuterol, the Zopanex, and the dual neb. But now if you have albuterol, Pulmicort, and the Mucomist, what you want to do is you want to do the albuterol and the Pulmicort and open them up real good, and then you want to do the Mucomist afterwards because you didn't open them up real good, and then you want to do that Mucomist after to break it all loose real good. Does that make sense?
Mm-hmm.
So the Pulmicort can be given mixed with the bronchodilator, but the Mucomist has to be separate and given after.
Yeah. Unless, the Mucomist can be given if there's no Pulmicort. Does that make sense?
Yep.
If there's no Pulmicort in it, it can be given with this Zopanex, albuterol, to do it.
Gotcha.
But if it's all three of them, then it needs to be given last.
Okay.
Got it?
Mm-hmm.
Okay. As long as it's given with a bronchodilator, that Mucomist has to be given with a bronchodilator regardless. Monitor the use of MDIs and assure that the same medication isn't being delivered in a nebulized form. So which means make sure that you're not being given a Provenal, a Combivent inhaler, an Advair inhaler. Make sure you're not given the same thing. An Advair is the same thing as a Pulmicort.
Very often they're given the handheld nebulizer and the
Every
liquid
now
form.
and then you'll see it.
My son has both.
Now they may be a Provenal that might be like as a rescue. They're doing more as a rescue now or whatever. Never leave a resident unattended when doing a neb treatment. I know when I first started doing this, I know I had to stay in the room. Yeah. Here's another thing too. It's not on here for MDIs or whatever, but if you have somebody that's on an MDI and you notice them that they're not doing an MDI correctly, they need to really be switched to a neb. So, because the proper way of doing an MDI,
It's tough.
90% of the people are doing them incorrect. They're sticking them in the mouth. They don't go in the mouth. They go 2 finger lengths out.
Can you say that again?
An MDI, I'm throwing this in here because I know 90% of the people do an MDI correctly. An MDI goes 2 finger lengths out, so that it will stick right here. This is the MDI. It sticks out here. Right here's the thing. It don't go in their mouth. It sticks right here. So whenever they blow out, and then they go to inhale, you squirt it, and then they inhale.
That's why you use spacers.
And that's what I'm gonna say. And then if they can't do that, then you get them to do the spacer. If they still can't do it correctly, then they would need to be switched to a breathing treatment. Yeah. But you have to have an order for a spacer.
Right.
Yeah. All right. We'll go over the test here. Indications for a nebulizer treatment are
F.
A through C.
a bronchospasm, mobilized secretions, and COPD and asthma.
They sure don't facilitate sleep, I'll tell you that.
Right, it'd be nice, right?
Ooh.
What is the device used to nebulize medications?
It's a small volume nebulizer.
Small volume nebulizer. Neb treatments, which is bronchodilators, are used to treat reversible bronchospasm.
Yes.
True.
True. When should a caregiver listen to breath sounds?
Before and after.
Before and after?
After and during, all of them.
No.
Nope.
Heart
this-
rate is before,
That's a
after,
heart
and
rate.
during.
It's before, during, and after. Side effects of albuterol could be,
A and B.
it could be all. Remember the infection
Oh, from the equipment.
contaminated. Mhm.
Okay.
They just haven't fixed that yet. Yeah. At what point would you stop a treatment in relation to the pulse rate?
C.
20 points above the starting rate.
Yep.
And that's it.
All right. Thank you very much, Angela.
You're welcome.
Bye-bye.